Yeah, do you have any further information?
Negative, Medic 12, not at this time. We are trying to reconnect with the caller at this time. All we know is that it's back in the recycling center. Young male with a severe leg injury. The caller was quite excited and hung up. We have not been able to reconnect. Again, we're trying to make contact with somebody there to see if we can get you additional information.
That's clear, dispatch.
All I know is some kind of leg injury.
Okay.
He got caught in the machine. His leg's over there.
Over the last decade, lessons learned from battlefield medicine have taught us many things about how we should prioritize our care for the trauma patient. One of the most important lessons learned has been to make exsanguinating hemorrhage our very first clinical priority. We'll teach you how to save someone from life-threatening bleeding and hemorrhagic shock on this episode of Medic Monthly. I'll put it bluntly. Too many of our trauma patients are dying from preventable hemorrhage in the pre-hospital setting. But it's not your fault, as a lot of our teaching in this area has been inaccurate and sometimes flat out wrong. You may have been taught that all external bleeding can be controlled with good direct pressure, or maybe limb elevation with the application of some pressure points. Maybe you learned to keep piling on more and more dressings, bandages, and 4x4s or Curlex on a bleeding wound that keeps soaking through. And of course, there's my favorite. Never use a tourniquet unless it's a last resort and you're willing to sacrifice that limb. Well, with bad advice like that, it's no wonder that so many of our patients still bleed to death in the presence of emergency responders. Trauma has been called the neglected disease of modern society, and it remains the #1 cause of death between the ages of 1 and 39 years old, even outside the military. While head injury is the #1 cause of death among these traumatically injured patients, exsanguination, or bleeding to death, is a close second, and it is the #1 cause of preventable death in the field. This is why exsanguinating hemorrhage control is the #1 clinical priority in trauma care, even before airway management. Now, to understand why bleeding control is of such great importance, we should understand what happens to the body when we lose this essential and precious resource, blood. Our body requires a sufficient volume of blood to supply oxygen and essential nutrients to our cells and maintain the delicate balance of homeostasis. When we bleed excessively, it disrupts almost every critical body function, including respiration, thermoregulation, immune function, metabolic waste removal, and coagulation. Hemorrhagic shock is a type of hypovolemic shock caused by excessive blood loss. The average healthy adult has about 5 liters of circulating blood at any given time, and most of us can lose about 750 cc's, or 3/4 of a liter, before we begin to show outward signs of blood loss like pale skin, anxiety, and an elevated heart rate. So, how much blood are we really talking about? Most of us can estimate how much liquid is in a container sitting on a shelf because we have a lot of experience seeing liquids in containers. But what about when the liquid is spilled on the ground? So, here's about a liter of fluid spilled on the ground. This is the volume of blood loss where we would expect to see signs of compensated shock. That would include tachycardia, diaphoresis or sweating, anxiety, and dilated pupils. While blood loss is never good for our patient, most healthy adults will tolerate the loss of a liter of blood. But what if the bleeding continues? Somewhere between 1.5 and 2 liters of blood loss is where our patient will enter decompensated shock. This is where the body can no longer compensate for the decrease in circulating blood volume. Tissue oxygen demands increase, and the body has no ability to meet the increased oxygen needs. Lack of blood volume also causes coagulopathy, or an inability of the blood to clot and prevent further bleeding. Impaired circulation and central shunting of blood will cause a drop in body temperature, and the onset of hypothermia further serves to impair normal body function. In this state, we will see the patient's level of consciousness transition to confusion, lethargy, and ultimately unresponsiveness. Skin may be pale or ashen, cool to the touch, and possibly cyanotic. It may feel wet or dry. The heart rate and respiratory rate will remain high, but blood pressure will drop. This falling blood pressure is the most reliable clinical sign of decompensated shock. This deadly triad of metabolic acidosis, coagulopathy, and hypothermia can quickly spiral into irreversible hemorrhagic shock and death.
Let's go ahead and get a tourniquet on him.
Yep.
If you want to do a non-rebreather, 15 liters.
Alright, sir, we're gonna take good care of you.
Whenever you're ready, Amanda, I'll go ahead and lift the leg up.
Alright, I'm ready.
What's on?
Nice and tight.
Alright, we're here. Okay, looks like the tourniquet's controlling the bleeding. I'm going to do everything en route. Can you guys get the combi board? We'll get them onto the stretcher. You bet.
When we recognize life-threatening external bleeding, our task is simple: stop the bleeding. However, just because something is simple doesn't mean that it's easy. Applying enough pressure to wet tissue with enough force to occlude an artery can be surprisingly difficult. Remember that the goal is to apply a lot of pressure to a small area where the bleeding is present. This may mean initiating bleeding control with your gloved hand while your partner finds the bandages. In your EMT or paramedic classes, you may have been taught to press hard against the wound with a bulky dressing. But large dressings and even the surface of your hand may spread the pressure out over too large of a surface area. Sometimes the most effective technique may be just trapping the bleeding tissue between 2 or 3 fingers and the patient's bone. You also may have been taught that for extremity bleeding, you should hold pressure on a pressure point, like the groin or axilla of the arm. This technique may be helpful, but you'll need to understand that applying the amount of pressure necessary to be successful at this technique is problematic at best and nearly impossible in some patients with a larger body habitus. In fact, for lower extremity injuries, some military and tactical personnel are being taught techniques like knee to pocket that involve kneeling with their entire body weight on the patient's inguinal area while deploying other bleeding control devices. This type of full body weight pressure is more likely to occlude the underlying arteries and slow the bleeding. Something else that you may have learned is to keep applying more and more clean dressings on top of saturated bloody dressings. This is not helpful for several reasons. The dry dressings draw more blood away from the wound and inhibit clotting of blood within the innermost dressings. They also serve to spread out the pressure again over a large surface area, making bleeding more likely. It also makes the effectiveness of bleeding control efforts harder to assess. If the patient continues to bleed after the initial dressings have become saturated, then address the problem with more pressure, not more dressings. That may mean you have to put more direct pressure or use a tourniquet. Tourniquets, once taught to be a last resort option only, should be the first line of treatment for many instances of hemorrhage. Modern tourniquets are safe and effective, can be placed in seconds, and stay on a limb for several hours without significant complications. But there are still some tips and tricks to deploying them quickly and effectively. Commercially produced windlass, ratchet, or pneumatic tourniquets are all pretty effective at reducing or eliminating arterial blood flow. However, the elastic or bungee type designs are generally not recommended for pre-hospital use, and improvised tourniquets should only be considered if a commercial option is unavailable. For the patient with life-threatening bleeding, every second truly does count, so we recommend that the tourniquet be stored out of its package and in a readily accessible area of the medical kit. Wrapping the tourniquet around the limb is fast, but sliding it up the limb from a pre-deployed fashion is even faster. The tourniquet should be placed high and tight above the wound, meaning near the armpit if controlling an upper extremity injury, and up near the groin if controlling a lower extremity wound. Care should be taken to avoid placing tourniquets over a joint. One very frequent mistake is relying too much on the windlass to apply the pressure to the limb. The real work of a tourniquet is done by the strap itself. Cinch down the tourniquet strap as tight as you physically can before beginning to turn the windlass, crank the ratchet, or inflate the pneumatic bladder. This is not comfortable for the patient, and it's not intended to be. Keep cranking until the distal pulse is eliminated. If one tourniquet isn't adequate to control the bleeding, you can also consider using a second tourniquet higher on the same limb. The second tourniquet should be next to, if not touching, the original tourniquet. For large diameter limbs, most commercial tourniquets can be combined with a second to double the diameter of the strap. Traumatic amputations can be emotionally charged scenes, and with other care priorities demanding our attention, like bleeding control, sometimes care of the amputated limb itself can get lost in the shuffle. But a responder who is properly trained in how to care for an amputated part or limb can significantly improve the patient's chances of having a successful limb reattachment. A limb amputation can be complete or partial. If the limb is still attached to the patient by soft tissue like skin, ligaments, or muscle, every effort should be made to preserve the limb's existing connection to the body. Whenever possible, use your existing splinting, wrapping, and immobilization tools to protect the partially amputated limb in the position of function. If there is a complete amputation of a limb or part, on-scene personnel should be assigned to the retrieval and recovery of the amputated anatomy with the goal of preservation and eventual reattachment. Cover the amputated part with a saline moistened gauze and seal it in a clean, waterproof plastic bag. When possible, place the bag over ice. If ice is unavailable, cold packs may be used to reduce the temperature of the amputated part. Every effort should be made to avoid the limb tissue coming in direct contact with ice, as this can result in damage to the tissue. Also keep in mind that limb or part recovery should never delay the transport of an unstable patient. Amputated parts can be transported in a separate vehicle by other responders not involved in direct patient care. Major trauma patients require us to rearrange our usual ABC plan of care. Some useful acronyms to help us remember our care priorities in major trauma include things like XABC or MARCH. XABC stands for exsanguinating hemorrhage, airway breathing circulation, while MARCH stands for massive hemorrhage, airway respiration circulation, and H for hypothermia avoidance. Let's look at the first letter first, M, massive hemorrhage. And when we say massive, that's a pretty good description of what we're looking for. Not all bleeding should be addressed before assessing the patient's airway. Only significant arterial, life-threatening bleeding. If you see a large amount of blood loss or rhythmically spurting arterial type bleeding, stop the bleeding first, then address priorities like airway and breathing. Tourniquets are highly useful in stopping limb bleeding, but what about injuries on the torso or abdomen? What about injuries too high on the limb to allow for tourniquet use, like the shoulder or hip joints? For these injuries, strong direct pressure and perhaps aggressive wound packing might be our only options. Another treatment option, if you have it, is hemostatic gauze.
Over here.
Keep breathing. Keep breathing.
He's really hurt.
Give me 2 and 3.
Okay.
Yes, we got him. We're gonna get him out of here, okay? Yep, ready. Let's move. You guys ready? Ready to move.
Hemostatic gauze is simply bandaging that is impregnated with a substance or agent that promotes the clotting process. The area of bleeding is first addressed with strong digital pressure, and then the hemostatic gauze is packed tightly against the bleeding vessel inside the wound. Once personnel are addressing massive hemorrhage at the source, the airway is our next priority. Consider the need for high-flow oxygen, airway adjuncts like nasopharyngeal airways to maintain airway patency, and the rare but possible need for a surgical airway. When you've established a patent airway, assess the patient's respiration or breathing. If the patient is failing to breathe adequately, BVM assistance may be necessary and intubation might be considered. This is also a good time to assess for possible pneumothorax and consider the need for needle decompression. Next comes circulation, and this is where our treatment can become a bit complex. Appropriate fluid resuscitation in our bleeding patients is a subject of much debate in medical circles. Traditionally, support for hemorrhagic shock has consisted of stopping the bleeding and administering large volumes of IV crystalloid fluid. And while our bleeding control historically might not have been aggressive enough, our fluid administration has likely been too aggressive. To be sure, replacing large volumes of the patient's blood with normal saline or other crystalloid is not a cornerstone of good trauma care. Blood is actually harder to replace than you might think, and the patient is dependent on the clotting mechanisms in their blood to stop the bleeding. Too much crystalloid contributes to coagulopathy and bleeding. Increasing the patient's blood pressure can also contribute to the patient's bleeding. Thus, while establishing 2 large bore IVs is still acceptable in major trauma, transport should not be delayed for vascular access, and once achieved, boluses of crystalloid infusion should probably be reserved for patients with depressed mental status and not simply hypotension. When it comes to permissive hypotension, you'll need to let your local protocols and your clinical judgment be your guide. Our last consideration in the MARCH acronym is hypothermia. For a variety of reasons, we allow many of our trauma patients to become hypothermic during our care. Delivering our patient to the trauma team hypothermic is more than just a comfort issue. Hypothermia in trauma has serious implications for patient outcomes. Hypothermic patients experience impaired cardiac and liver function. They are also more susceptible to infection. Hypothermia-induced coagulopathy also makes these patients more likely to continue bleeding. For a multitude of reasons, patients who arrive hypothermic at the trauma center have significantly higher mortality than patients who arrive normothermic. So as soon as possible, crank up the heat and cover your patient with blankets to help preserve their body temperature. While placement of a cardiac monitor is of lower clinical priority in a major trauma patient and should only be placed after all other care priorities have been addressed, its clinical value should not be underestimated. For example, any rhythm less than 60 beats per minute is considered bradycardic. And if you're treating a shock patient who is a victim of trauma, bradycardia is almost always an ominous sign. Bradycardia and pulseless electrical activity are the two most common rhythms seen in trauma patients who are decompensating into cardiac arrest. When you see a rhythm like this one in the presence of trauma, your first priority is to identify if the patient still has a pulse. If not, you need to begin CPR. Then it's important to consider what factors may be causing this rhythm that we might be able to correct. If your trauma patient deteriorates into PEA, you've got to think about these 5 things: hypoxia, hypothermia, hypovolemia, cardiac tamponade, and tension pneumothorax. After assessing and treating any possible reversible causes, following your ACLS guidelines for cardiac arrest is appropriate, though hypovolemic patients who transition into cardiac arrest typically have a very poor outcome. The trauma patient presents us with multiple assessment priorities in rapid sequence. Remember that the physical assessment is an ongoing process while caring for these patients. While you may get consumed with immediate or life-threatening care priorities, you'll still want to fall back and perform a rapid trauma assessment as soon as time permits, and you'll want to accomplish a detailed physical exam prior to arrival at the emergency room. You may be asking where C-spine immobilization fits in all this. Backboards and full spinal immobilization do not seem to benefit trauma patients, and, in the case of penetrating trauma, may actually increase mortality. If you feel that the patient is at risk for cervical spine injury, we recommend the use of a C-collar and gentle patient handling. Backboard should be reserved for patient movement and extraction, not full spinal immobilization for transport. There are some things about a trauma scene that a hospital-based medical provider will never be able to observe. These are the points where your documentation will serve as a valuable reference for the medical team. For penetrating wounds, a detailed description of the object or weapon can be invaluable. The caliber or estimated range from a shooter may be important. So is the size of a knife blade and estimated depth of penetration. The approximate time of injury may be useful, particularly if there was a prolonged extrication or delay in delivery to definitive care. Because tourniquets can be applied to a limb for several hours, it is less useful to write the time of application on it, especially in areas with relatively quick transport times. But if you know it, then sharing the time of application with the receiving hospital can be useful. If there has been a significant amount of blood loss, your estimation of blood loss on scene may help guide the aggressiveness of blood product resuscitation during the first hours of care. From the inception of EMS, trauma care has played a large role in our storied and colorful history. It's also been the source of some of our biggest controversies in medical care. Today, there are still providers who resist ideas like using a tourniquet as a primary means of bleeding control, or entering a potentially violent scene under police escort, limiting the use of IV crystalloid boluses in a trauma patient who's hypotensive yet fully awake, or disregarding the use of a long spine board altogether. Perhaps more than any other area of our medical care, trauma management requires us to keep an open mind, consider new approaches, research what works and what doesn't work, and to stay current in the literature and in your continuing education. Thanks for watching. Be careful out there, and we'll see you on the next episode of Medic Monthly.